Hi students, welcome to the physiology of thyroid gland. So in this topic we will learn about the physiology and the pharmacological aspects of thyroid gland and also the clinical importance. So where is the thyroid gland located? Yes, in the anterior part of the neck. So any swelling in the thyroid gland will obviously present as a swelling in the anterior part of the neck. So look at the histology of the thyroid gland. It has follicular cells. So the green colored cells are the follicular cells, and inside the follicular cells you have this purple colored space which is called as the colloid. See, this arrangement is important because the follicular cells along with the colloid together they will help in the thyroid hormone synthesis. And parafollicular cells, so look at the dark green cells, they are the parafollicular cells or the C cells. So they produce calcitonin. Follicular cells and colloid are going to produce the thyroid hormones, whereas parafollicular cell will produce calcitonin. Let's learn about the synthesis of thyroid hormones. First of all, what is the trigger for production of these thyroid hormones? Your hypothalamus produces TRH. See, I already told you all releasing hormones of the anterior and posterior pituitary are produced from the hypothalamus. The hypothalamus produces TRH. This in turn acts on the anterior pituitary, and anterior pituitary produces TSH, thyroid stimulating hormone, which in turn acts on the thyroid gland, and thyroid gland produces your thyroid hormones T3 and T4. So what are the steps in hormone synthesis? So starting with the first step, trapping of iodide. So this is done by your follicular cells. So you have arrangement of follicular cells, and this is the blood flow. So when blood flows across the follicular cells, the iodide which is present in the blood. So who will give iodide to the blood? Yes, the diet that you eat, it contains iodine, and when iodine is absorbed from the intestine, it is absorbed in the form of iodide, and this iodide enters the blood. And this blood carrying the iodide, when it flows in the circulation, when it comes across your thyroid gland, if it crosses the follicular cells, it is quickly trapped by the follicular cell. So how is it trapped? By a channel called NIS. NIS means sodium iodide symporter. So it's a type of secondary active transport. So why is it secondary active transport? Because sodium along with iodide is moving in the same direction. So it's called as a secondary active transport. And this step is called as trapping of iodide. So what is the stoichiometry of this channel? 2 sodium is to 1 iodide. This iodide, which is trapped by the follicular cell, moves on the other side of the cell into the colloid. See, already we saw all the follicular cells, they will open into the colloid. So it opens into the colloid. And how is this iodide moving into the colloid? By a channel called pendrin. So pendrin is clinically important because pendrin is actually an antiporter. Antiporter means iodide is moving into the colloid in exchange for chloride which is moving into the follicular cell. So iodide and chloride are moving in the opposite direction. So it is called as an exchanger. And how is it important clinically? See, any mutation of pendrin, the gene for pendrin, if it is mutated, it can result in congenital hypothyroidism. Why hypothyroidism? Because this step is blocked. So no thyroid hormone synthesis. So it can cause hypothyroidism. And also pendrin is present in the inner ear. So inner ear in the sense it is responsible for hearing. So any mutation of pendrin will affect hearing. So it results in congenital deafness. So if a patient presents with hypothyroidism along with deafness, it could be Pendred syndrome. So this is called Pendred syndrome. Mutation of pendrin, the iodide chloride exchanger channel. So now this iodide comes into the colloid. See what happens in the colloid. It undergoes 3 steps in colloid. Oxidation. Oxidation is iodide is again oxidized into iodine. It's called oxidation. And for oxidation, you need an enzyme called thyroid peroxidase. This is important because On the clinical side, you have drugs which can block this thyroid peroxidase, thereby used in the treatment of hyperthyroidism. So what are those drugs? Propylthiouracil, methimazole, and carbimazole. So where do you use these drugs? If a patient has more and more thyroid production, thyroid hormone synthesis, if you give them these drugs, they will quickly block thyroid peroxidase. If the enzyme is blocked, this oxidation step will be blocked. So the entire mechanism of synthesis of thyroid hormone will be blocked. Thereby, it will help you to bring down the levels of thyroid hormones. And also, thyroid peroxidase not only helps in oxidation, it also helps in organification. So what is organification? Binding of tyrosine to iodine is called as organification. So for organification also you need thyroid peroxidase. So if you give these propylthiouracil, methimazole and carbimazole, it will block organification step also. So what is organification? Binding of tyrosine to iodine. Where is this tyrosine present? Tyrosine is present on Tg. Tg means thyroglobulin. So tyrosine is present over the thyroglobulin molecule, and iodine combines with this tyrosine, that is called organification. And when one iodine combines with one tyrosine, it will form MIT. What is MIT? Monoiodotyrosine. It's called MIT. And now coupling takes place. What is coupling? See, they just join together. That is called coupling. So look at this. One MIT combines with another MIT to form DIT. DIT is diiodotyrosine. Or one MIT can combine with one DIT to form T3, triiodotyrosine. And one DIT can combine with another DIT. 2 plus 2 is 4. So it can form T4. So this is how T3 and T4 is synthesized. And all these reactions together, it is called coupling reactions. And the enzyme responsible for this is again the thyroid peroxidase. So if you give propylthiouracil, it is going to block coupling also. So all these three group of drugs, propylthiouracil, methimazole and carbimazole, they block all three steps in colloid: oxidation, organification and coupling. One other group of drugs which can also be used to treat hyperthyroidism is you can block the first step in thyroid synthesis. What is the first step? Trapping of this iodide itself is blocked. So blockers of NIS, which is your thiocyanate and perchlorate. So thiocyanate and perchlorate, they block the trapping of iodide, the first step itself. Therefore, they can also be used in the treatment of hyperthyroidism. So now T3 and T4 are synthesized in the colloid and they are stored inside the follicular cells. They can be stored even for 2 to 3 months, and whenever needed, they are released into the circulation. They are released into the blood. So now let's see what happens when they are released into the blood. So once they are released into the blood from the gland, T3, T4. Which do you think will be more, T3 or T4? So how to easily remember this? T4 is more, 4 for more. So T4 is more. Then what is T3? T3 is less produced, but it is the active form. So T4 is more produced, but T3 only is the active form. So you understand that even though more of T4 is produced, all of this will be converted into T3 in the periphery, because T3 only is going to be the active form. And in blood, 99.9% of thyroid hormones are in the bound form. They are bound to plasma proteins. So what are the proteins to which they are bound? So 75% of the thyroid hormones are bound to thyroid binding globulin or thyropexin. Thyropexin. 20% is bound to prealbumin, otherwise called transthyretin, and remaining 5% is bound to albumin. This is a repeat question. Which of the protein has maximum affinity to thyroid hormones, thyroid binding globulin or thyropexin? So this bound form cannot exert its actions. Only the free form is physiologically active. So eventually, whenever needed, it will be released from bound form into the free form. And once it is released, so it is released into the periphery, and in the periphery, T4 is converted into T3. So why should T4 be converted into T3? Yes, because only T3 is the active form. And the enzyme which helps in this reaction, it's called deiodinase. Deiodinase. So what's the function of deiodinase? It converts T4 into T3, the active form, and T3 will exert all its functions. So this is how thyroid hormones are synthesized, moved into the periphery, and T3 exerts its action. Actions of thyroid hormone. So before learning about the actions of thyroid hormone, let me tell you about two important effects in thyroid hormones. So they are called as Wolff-Chaikoff effect and Jod-Basedow effect. So what is Wolff-Chaikoff and Jod-Basedow? So the trigger for both the effects is the same. So the trigger is excess iodide. So whenever you have excess iodide, you can have dual effects. Excessive iodide levels, sometimes it can cause decrease in thyroid hormones and can result in hypothyroidism. And this effect is called as Wolff-Chaikoff effect. On the other hand, excess iodide can also result in increased thyroid hormone synthesis and can result in hyperthyroidism. This is called Jod-Basedow effect. And how we used to remember this is, so the mnemonic is job. Job is Jod-Basedow effect. So when you have a job, you will be hyperactive. So Jod-Basedow effect, hyperthyroidism. Next, let's learn about actions of thyroid hormones. So I'll teach you an easy method to remember the actions of thyroid hormones. Just remember the word rates. Thyroid hormone increases all rates in the body. So what are all the rates which are increased by thyroid hormones from head to toe? Starting with the brain. Thyroid hormones increase the rate of brain growth. That is why clinically, if you correlate with hypothyroidism, congenital hypothyroidism is otherwise called as cretinism. Hypothyroid babies, they present with mental retardation because the function of thyroid hormone is to increase your brain growth. In lungs, thyroid hormones increase the respiratory rate. In heart, they increase the heart rate. So that is why hyperthyroid patients, clinically they will present with increased heart rates. What is increased heart rates called as? Tachycardia. On the other hand, hypothyroid patients present with decreased heart rate. Decreased heart rate is called as bradycardia. And thyroid hormones, they increase the rate of conversion of carotene into vitamin A. That is why hypothyroid patients, they cannot convert this carotene into vitamin A. So there is excessive accumulation of carotene in hypothyroid patients, and this carotene gives the yellowish pigmentation to the skin. So this is seen in hypothyroid patients. On bones, thyroid hormones increase the rate of bone growth. That is why hypothyroid patients, hypothyroid cretins, they are dwarf, they have stunted growth. And thyroid hormones increase the rate of stretch reflex. That is why hyperthyroid patients, they have increased stretch reflex, and hypothyroid patients, they have slow stretch reflex, or it's called as sluggish stretch reflex. So what other rates are increased by thyroid hormones? Thyroid hormones increase the rate of proteolysis. What is proteolysis? breakdown of proteins is called as proteolysis. See, that is why clinically hyperthyroid patients, there is excessive breakdown of muscle proteins in hyperthyroid patients. That is called as thyrotoxic myopathy. Thyrotoxic myopathy. To the intestines or the GIT, thyroid hormones increase the rate of gastric motility. That is why clinically hyperthyroid patients have increased gastric motility. So what is the symptom of increased gastric motility? Yes, you will have diarrhea. And hypothyroid patients decreased gastric motility. So they will have constipation. And thyroid hormones, they also increase the rate of glucose absorption. Glucose absorption. See, that is why as soon as you eat a carbohydrate rich meal, all this glucose will be quickly absorbed into the blood, thereby resulting in hyperglycemia. Hyperglycemia. But after some time, the same thyroid hormone, it also increases the glucose utilization by the cells. So when all the cells begin to utilize the glucose, blood glucose level will slowly come down. So at later stages, it results in hypoglycemia. So it can cause both hyperglycemia initially and later hypoglycemia. And what it does to the adipose tissue. So in adipose tissue, it increases the rate of lipolysis, fat breakdown. That is why hypothyroid patients have excessive accumulation of fats. They have increased triglycerides and they have increased cholesterol. So these are all the clinical presentations of hypo and hyperthyroidism, and you know how to relate with the actions of thyroid hormones. And on the whole, thyroid hormones, apart from increasing all these rates, they also increase the basal metabolic rate, which is very, very important to remember. They increase the basal metabolic rate, which is called BMR. So when your basal metabolic rate increases, what do you mean by that? All metabolisms inside the body are increasing. So when all metabolisms increase, as a result, there is more oxygen being consumed. So it increases oxygen consumption. And this is called calorogenic effect of thyroid hormones. When your metabolism increases, as a result of metabolism, increased heat production. So that is why hyperthyroid patients, they cannot tolerate heat because already there is more heat produced in the body. So that is called heat intolerance. One of the important clinical features of hyperthyroidism, heat intolerance. And hypothyroid patients, cold intolerance. And as a result of all these metabolisms taking place, there is increased weight loss. Weight loss. So that is why hyperthyroid patients, they are very lean, they have weight loss. And on the other hand, hypothyroid patients, they have weight gain, they are fat, weight gain. So these are all the actions of thyroid hormones and how you will clinically correlate them. Next, let's move on to disorders of thyroid gland. So one disorder is that you can have excessive production of thyroid hormones. On the other hand, you can have deficiency of thyroid hormones. So what is excessive production of thyroid hormone called as hyperthyroidism? And the most common cause of hyperthyroidism is Graves' disease. So what is Graves' disease? So it's an autoimmune disorder. So what do you mean by autoimmune disorder? Body will start producing antibodies against the self itself. That's called autoimmune disorder. So you have autoimmune antibodies. The most important antibody produced here is TSH receptor stimulating antibody. So what this antibody does, it keeps on stimulating the TSH. When TSH is stimulated, this will increase T3 and T4 production from the gland, and the gland also will become hyperactive because constantly it will keep on producing T3 and T4. So the gland is hyperactive. See, whenever the gland is hyperactive, it tends to enlarge, and that enlargement of the gland is called as goiter. So any swelling of the gland is called as goiter. And keep in mind, goiter can be a presentation in hyperthyroidism as well as hypothyroidism. So this any swelling of the gland is just called as goiter. And one other important clinical feature seen here is exophthalmos. See, look at these eyes. Exophthalmos is when you have autoimmune antibodies. So one type of antibody is TSH receptor stimulating antibody, and there are also antibodies which can destroy the muscles around the eyeball. So when muscles around the eyeball, the eye muscles are affected, it results in protrusion of the eyeball. The muscles are damaged, so the eyeball protrudes from the socket. That is called as exophthalmos, a very important clinical feature seen in Graves' disease. So this is about hyperthyroidism. On the other hand, hypothyroidism, any deficiency of T3 and T4 is called as hypothyroidism. In a child, hypothyroidism is called as cretinism. And in adults, hypothyroidism is called as myxedema. The other name for myxedema is Gall's disease. Typical clinical presentation of this myxedema is edema. Edema is swelling. So edema present around the shin, as you can see in this diagram. So on the shin of the tibia, on the anterior part of the leg, you can see edematous swelling. So what is this swelling due to? Excessive deposition of hyaluronic acid as well as chondroitin sulfate. So both these substances, they form a gel-like matrix in the extracellular space. So that is the reason for the swelling or the myxedema. So this is about myxedema in adults and cretinism in childhood. Another important clinical presentation of thyroid gland is Hashimoto's thyroiditis. So Hashimoto thyroiditis, this is an autoimmune disorder. So what do you mean by autoimmune disorders? Body produces autoantibodies against its own self. That is called as autoimmune disorder. So in Hashimoto's thyroiditis, you have auto destruction of the gland. So the gland is completely destroyed. Therefore, insufficient thyroid hormones, that is called hypothyroidism. So Hashimoto thyroiditis will eventually result in hypothyroidism. So one other clinical presentation of thyroid disorder is iodine deficiency goiter. Iodine deficiency endemic goiter. So this happens because of deficiency of iodine. So when you have deficiency of iodine, there is decreased production of T3 and T4 because iodine is the raw material for synthesis of T3 and T4. So when you have iodine deficiency, T3, T4 decreases. As a result, this will give a negative feedback on the anterior pituitary. So anterior pituitary will think that, okay, T3 and T4 are being less produced. So let me produce more of TSH. So there is increase in TSH. This TSH in turn acts on the thyroid gland. Without knowing that there is no iodine, TSH will keep on stimulating the thyroid gland, trying to produce more of T3, T4, but eventually there is no iodine. So how much ever it is stimulated, it can't produce T3 and T4. So what happens? This increased TSH acting on the gland will try to increase the activity of the gland, thereby increasing the size of the gland, or it's called as goiter. Therefore, it results in overactivity of the gland, which is called as goiter, or simply swelling of the thyroid gland. But hormone levels are actually less. It's just trying to produce more of hormones without knowing there is no iodine. So how will you treat these patients? So the easiest method is food fortification. So what is food fortification? Using of iodized salt. In Tata salt advertisements and all you would have seen, it's an iodized salt. So why do you use iodized salts? because it contains iodine. So if an entire population is affected by this iodine deficiency endemic goiter, you just fortify all the food that is going to that population with iodine, which can easily correct this iodine deficiency endemic goiter. So this completes the thyroid gland and its disorders. Let's move on to the next gland.